Okay, so it is about 8:01. I'm thinking we should probably get started just in the interest of time to ensure that we have some time at the end to take questions from the audience. So good morning, everyone. My name is Michelle Mohan. Welcome to Provincial Stroke Rounds. I am the Regional Education Coordinator with the Toronto West Stroke Network based out of Toronto Western Hospital. Today's presentation is titled Stroke in Young Adults, Patient-Reported Outcomes and Psychosocial Needs, and is being presented by Dr. Alexandra Pakula. Before we get to the presentation, I'm just going to run through a few quick housekeeping items with you. First off, this presentation will be recorded and archived. You'll be able to access it through a link that we will be sending out after this session is completed. Slides from this session will also be included in that email. A reminder that the views being expressed today are those of the presenter and not of the platform that we're using. We are asking everyone to please ensure that your microphones are on mute throughout the presentation, unless someone at your site or unless you are asking a question. You can just go back to the other slide, Dr. Pakula, the first slide. Thank you. We will be having a question and answer period at the end of the presentation. However, if a question does occur to you as we're going through the presentation, please do feel free just to type that into the chat box. We will be monitoring that, and we'll ensure that Dr. Pakula gets that question at the end of her presentation. We are asking that everyone in attendance please do complete an attendance form as well as an evaluation. If you just look on your screen here, this first slide, you can see that there is a link as well as a QR code that would allow you to complete the evaluation online. There is also the option to complete a paper copy that was attached in the email invitation that we sent out to you a few weeks ago. If you are completing the paper copy, please do remember to send the completed evaluation to the email address that's just listed at the bottom of that sheet. Similarly, with the attendance sheet, just send the completed version to the email address that's listed at the bottom of the sheet. Certificates of attendance were also included in the email invitation that we sent out. So you can use those, feel free to fill them out and just hang on to them for future reference. So if we go to the next slide, you can see here that the Provincial Stroke Rounds Committee has mitigated bias for this presentation. So as I mentioned to you before, our speaker today is Dr. Alexandra Pakula. Dr. Pakula is a vascular neurologist at the University Health Network's Toronto Western Hospital, a clinician investigator at Krembil Brain Institute, and an assistant professor of medicine at the University of Toronto. She completed her neurology residency, vascular neurology fellowship, and vascular neurology epidemiology research fellowship training at Boston University, Harvard University, and Framingham Heart Study. Dr. Pakula is the director of the University Health Network Stroke Research Program and the co-director of Women's Neurology Fellowship at the University of Toronto. She is also the director of the Stroke in Young Adults program at the University Health Network, which is a multidisciplinary patient care model for distinct populations such as young adults with rare causes of stroke, with a specific focus on cerebrovascular disease in women across their lifespan. The research focus of this program is funding through CIHR, and it's funded as the Why Stroke Needs study, which is a study that aims to understand patient-reported outcome measures and is focused on development and implementation of innovative post-stroke tools to improve long-term functional outcomes and help optimize brain aging in this population. So welcome, Dr. Pakula. I will turn it over to you.
Thank you, Michelle. Thanks for a really kind and nice introduction. It is really my pleasure to be this morning with you and the audience and to talk about stroke in young adults with, as you said, focus on patient-reported outcomes and psychosocial needs. So I'm hopeful we'll be able to provide some light into this topic and focus on a more personalized approach to outcomes of our patients altogether. As you mentioned, support comes mostly from CIHR and UFT, and it's really only related to the research part of what I do. So the objective of this talk is that hopefully upon completion of what I will try to share this morning, you'll be able to identify the current gaps in supporting the needs of young persons with stroke based on available literature, which is quite limiting. I also hope that we'll be together able to describe the prompts such as patient-reported outcome measures and psychosocial needs of young persons with stroke through their lived experience. Again, we're learning a lot about this in coming times, and we'll certainly reflect on next steps to address and identify gaps to support the needs of young persons with stroke. So with that in mind, when we talk about outcomes, we certainly need to know more about patient before we come to the outcomes. So when talking about stroke in young, it's really important to mention the definition of young, what it means. What is the incidence or prevalence of stroke in young? What about the stroke severity in this population? And how that all reflects to a short versus long-term outcomes, such as recurrency of vascular events, including stroke, mortality in young. I'll also reflect on a current practice that's based on Canadian stroke best practice recommendation for managing transitions of care published in 2020 as a mention about a knowledge gap that hopefully will together in next years be able to close to a certain degree. So when we think about stroke in young, really the social and public health definition of young is anyone below 40 years of age. Young to mid-age is 40 to 64. But stroke studies are a little bit more liberal in that sense, and most of the new literature is reporting age as young being less than 50 or 55, while the older studies were looking into younger age at age of less than 45. As population is aging, there is also a shift to include mid-age or working population in this study, and this is a little bit of novelty. And there are several studies that are including patients that are younger than 65. So just to let you know that when I talk about studies in young, it will reflect actually the more current literature and will include mostly studies that are talking about patients less than 55. So when talking about stroke in young in regards to incidence, prevalence, or incidence even of traditional risk factors, we know that over the past 10 years, there is a massive increase in relative change in ischemic stroke prevalence in the States, 20 to 35% for population aged between 18 and 55, and even higher for those that are younger than 44. This is more obvious in women. It has certainly contributed to a certain degree to a higher burden of risk factors and lifestyle in this population. And interestingly, there is no change for intracranial hemorrhages and subarachnoid hemorrhage in this regard. This had been documented and seen and published in many other studies, including UK studies, recently Netherlands study that actually claimed 45% increase in stroke and mostly in ischemic stroke prevalence in population that's younger than 35. So certainly a concerning fact that should raise the question about our primary prevention, which obviously I'm not going to be talking today about, but a lot of room for improvement in that regards. This had been also seen across different population-based study, Kentucky, Framingham regards that are covering different racial groups. So certainly a recurrent theme and very convincing fact that stroke incidence and prevalence is climbing up in this population. The trends in hospitalization over the past decade in Canada also increased, as you can see, for years from 2011 up until 2016. I don't have more contemporary data, but I would assume that this is pretty much trending up or staying as stagnated, and specifically in populations such as younger than 40, as you can see, or even younger than 65. So definitely something that we're seeing here as well. Interesting paper that came recently out in Scientific American with commentary from the leads in this field, showing the trends that are different based on where people live. And as you can see, the curves are certainly climbing up in terms of stroke rates by urbanization category. And even though the rates are higher in the rural area, they're certainly not low in large cities. So millennials and those younger than 34 of age are certainly having more strokes than ever before. So there is a need to do something about that, but this would definitely reflect into outcomes that we'll be talking, and even patient-reported outcomes that will matter later on in their lives. So what about the stroke in young and severity? There is a lot of data published on this, and I just pulled numbers from Ontario Stroke Registry, where we looked at 23,000 patients with ischemic stroke only that are younger than 50, and most of the patients will have mild deficits. About 60% and large proportion would be discharged home. So it's something to remember and acknowledge that those patients, when they go home, they might bypass actually the usual pathways of care. About 30% of patients will have moderate severity in terms of disability, and about 10% will have severe disability. So looking at those numbers, we can say that overall physical prognosis is relatively good, but is that good enough for a person who had stroke and it's at a younger age and their full personal and professional growth? So talking about outcomes, there are several ways we look into outcomes. So again, data from Ontario Stroke Registry on short-term recurrence and long-term recurrence rates. As you can see, the rates are higher than previously reported. At 30 days, about 5% will have a recurrent event, and mortality rate was 10%. At 1 year, stroke recurrence rate is roughly 7%, and mortality is close to 20%. And this is mortality from many different vascular events, so not necessarily only stroke. Long-term recurrence rates also high at less than 5 years. Hazard ratios were 5.2 at 5 years for vascular events for young people, compared to 1.3 for older stroke patients, or compared with their match control. So certainly high recurrency rate and concern for perhaps improved secondary stroke prevention at this point. It's hard to say, but obviously another sort of gap that we should be thinking of perhaps improving in the future. Looking at a very long-term risk and predictors of recurrent ischemic events in the future study, which is a European study from the Netherlands, they look 25 years cumulative risk of recurrency. And as you can see, any ischemic event or even ischemic stroke event would happen in 1 in 2 or 1 in 3 people that already had stroke at younger age. So certainly high recurrency rate due to extended lifespan if the person has a stroke at the age of 40 or 50. Stroke in young, when we look at return to work, cognitive and psychosocial outcomes, there is not too much data out there. It's quite repetitive, but we could appreciate that even though the physical prognosis is good, the long-term functional outcomes are certainly not good enough. So young people are running low on everything. So they're not going back to work. At least in less than 50% of young strokes will go back to work. But if they do, 25% of those would require some sort of modifications at work. 80% of patients would have some psychosocial complaints in the form of depression, anxiety, pain, stigma, fatigue. 30 to 40% will have objectively measured cognitive dysfunction, such as processing speed, executive function, and even short and long-term memory dysfunction. And about 80% will complain about fatigue for at least 1 year, as documented in several studies, but most of them even longer. 50 to 70% would have some sleep disturbances, and that would essentially keep them in a vicious circle and cycle that will certainly impair them in terms of daily activities and return to work and personal life obligations. Given the lack of evidence, the 2020 Canadian Best Stroke Practice on Managing Stroke Transitions of Care obviously couldn't make a specific recommendation in place based on age or even on sex on this at this point, but certainly recognize the knowledge gaps such as need for patient-centered care. And I'm hopeful that with the next round of these recommendations, we'll be able to say a little bit more when talking about young versus older population in planning the recovery phase and transition of care of those specific groups. Another aspect when we talk about stroke in young is return to work and socioeconomic outcomes. We know from the studies that individuals from higher socioeconomic status and with professional backgrounds are more likely to return to work. Greater independence in ADLs and fewer neurological deficits, and obviously better cognitive ability were the most common predictors of return to work. And on societal level, individuals who do not return to work do impact the economy through a loss of productive years of employment and contributions. And we know from Public Health Canada reports, this is from roughly 2 years ago, when I reviewed this, that stroke costs the Canadian economy more than $3.6 billion per year, with the greatest economic impact likely being due to stroke among working population, because that population is expected to go back and continue contributing, and obviously expenses are massive. So it's really of great importance to optimize young stroke patients' occupational functioning and return to work, and hopefully have tools that will encourage and enable that. So we come to quality of life outcomes. Not much is published on young population, but few studies reported that factors affecting quality of life really varies with age. In older individuals, a low quality of life is associated with motor deficits and speech impairment, and we see that very often in the clinics. An elderly woman and man, if they cannot mobilize or talk and attend to their social activities, their grandchildren and their families, they are certainly more impacted than the young people who usually do rather well after stroke. But in young individuals, restriction in their job and leisure activities have a greater impact on well-being. And the way young people identify with the quality of life is measured by life satisfaction. So which it means they really are focused on occupational status, sexual life, physical and mental health. So these determinants that are quite different across the age groups certainly can help us perhaps streamline the recovery phase and transitions of care. So what all this mean to us and our young patients? So about 30% of all strokes will happen in working population. So it's pretty large number. And when talked to Dr. Mitch Elkin from Columbia, who is current AHA president, he made a comment about this increased incidence of stroke in young adults, that we're just seeing those little waves hitting the beach now, but that tsunami will come in the future. And it's really that tsunami that we're trying to protect with the improvement of transitions of care. But yet we also have to start from the awareness and prevention and work really sort of from the beginning to the end and circle that care pathway throughout in order to really understand what's happening with the stroke in young altogether. So that brings us to questions, which is, what are the limitations of outcome studies in contemporary stroke medicine? So what I see here, and I've been sort of exploring this for a couple of years now, it's that when you look at the outcome measures, really what we're doing, we're applying the outcome measures from acute care model to chronic disease care model, and that doesn't work. So what we use on a regular basis, such as NIH stroke scales and MRS and Barthel index, are excellent tools, but we need new innovative approaches and tools that can really help us identify the differences and age-specific outcomes that needs to be reported routinely. When we talk about these excellent tools for acute care, they're really only assessing short-term outcomes of functional status, and they can help us define effectiveness of our acute interventions, but they cannot help us identify a long-term individual patient's needs or assess the quality of life. So really, probably it's a time to shift from acute care model to a chronic disease care model with new tools that are emerging and will hopefully give us a little bit more understanding and insight about the outcomes. So that brings us to a patient-reported outcome measures. So talking about PROMS is quite exciting, and many other disease models such as diabetes and cardiac care and certainly cancer care are routinely using this on their patients. But it means that basically we're collecting health information directly from a patient, in this instance from stroke patient, as measures of a functional status, well-being, health-related quality of life, symptom burden, patient experience of care such as satisfaction with our provided care, health behaviors such as lifestyle prevention, taking ownership of their deficits and experience that they lived through the stroke care, and also gaining back their self-identity, which takes time after stroke. So it's really about satisfaction with life rather than success in life. So it's something that we routinely don't do. And there are not a lot of studies in stroke really focus on PROMS, but as I said, the data is emerging. A paper that I would certainly recommend highly to everyone to review, it's from Dr. Matthew Reeves on patient-reported outcome measures for acute stroke and how that can translate into chronic care model with all the rational methods and future direction, and how we can use and utilize those tools that could help us redefine the care model altogether. I won't go into details, but this is inventory of available scales that could be used. Most of the time we use EQ5D, which is assessing essentially a quality of life in general terms. However, there are two tools that were developed with intent to be used as outcome measures in clinical trials and for longer use in the clinics. And those are NeuroQOL and PROMIS-10. And I really want to emphasize them as probably the best that's available at this point. They're short in terms of applying them. They take about 5 to 10 minutes to utilize in the clinic. They assess different domains, really from physical, cognitive, social, different social and professional roles, depression, psychological status, a little bit more in depth, mental health, and vitality and energy that extends through other domains such as communication, stigma, sleep disturbances. There is also a questionnaire about sexuality. So it's a very wholesome approach to assess patient-reported outcomes altogether. They're all validated. They are tested in a stroke population. They're feasible in any setting. They're short and long forms. We mostly use short form, which was validated against the long form as well. There is no ceiling effect, which means really that there is opportunity to evaluate outcomes that you might pick up as the most important domain and follow through time and see how the patient does over a couple of years if there is interest. It's a continuous variable based tool. So basically T-score is generated at the end of each functional domain, and you get essentially a report with a number that has a meaning. So what it means actually if you would apply this against our routine functional scales. So I'll just take you to a hypothetical case that we would very often see in the clinic. So here is a 50-year-old woman. She's a teacher, but also primary caregiver of her husband with 3-year history of Parkinson's disease. She has 2 older kids. And she also has elderly parents. So you already get a sort of the heaviness of her responsibilities without any medical conditions in the background. She has a history of hypertension and diabetes. And she had a clinical event, woke up with mild left-sided weakness and dysarthria, came to a primary stroke center with NIH of 6, had a CT that confirmed right MC ischemic stroke, obviously didn't get any acute treatment due to time frame, but did quite well, uneventful hospital course, and was discharged home with some services. She was seen by her family physician at 8 days and then scheduled for neuro follow-up. So here's the table which illustrates the traditional approach where we measure outcomes that are collected by providers, so by us in the clinic. So, and we usually do MRS, which is totally appropriate just to see how she's doing. And as you can see, going through time from admission to essentially a discharge at 90 to 100 days in her primary care office, she improved from MRS of 3 to 1. Her Barthel index also improved from 90 to 100. So really, at this point, we can say that she's progressively recovering in function, and she can be discharged from the clinic, as we usually do after our first and initial 90-day follow-up in secondary stroke prevention clinic. However, if you would take that same patient through the patient-reported outcome measure, which would be a little bit new approach, and give her PROMIS system questionnaire, you can see actually that she's not doing as well. While on a PROMIS Global 10 PH, which is physical health, she improved with a higher score, meaning that she is getting better. This is reflective of her physical function, which can be paired with the traditional approach, and we know that she's improving physically. However, when you look at the Global 10 mental health and anxiety and self-efficacy in her ADL, you can see that she initially improved, but then she started actually getting worse. And if you would follow her over time, we would probably learn a little bit more about, her anxiety and probably apprehension about her ADLs with a social background that you already know about her. And that certainly brings her also on the verge of perhaps not being as engaged with secondary stroke prevention, not to mention about, medication compliance, which is an easy part, but really about, lifestyle changes that she also has to accomplish after the stroke event, which we always advise our patients to do, but we certainly don't have modes to follow up on that. So it's really an illustrative case to kind of make a point that we certainly have opportunities and tools to do a little bit better job in terms of assessing the outcomes and life integration and transitions of care in younger patients, in everyone actually, but in younger patients specifically, who have a little bit different social roles once they're back home. What are the challenges of PROMS? Well, the time and infrastructure, certainly for data collection, you need people for that. You need infrastructure in place and some sort of a routine that is run through clinic. PROMS would underestimate the needs in high MRS groups, meaning that anyone who has aphasia, neglect, or cognitive impairment would not be able to really communicate their answers correctly or in the way that we would like to receive them. There are challenges integrating PROMS into electronic health records if you're not using REDCap. REDCap actually is equipped with PROMS as a standard tool because it was developed by NIH, and generating results in a format and time that is useful to clinician might be challenging as well, because it's pretty robust report. So the advice is really to focus on the most important domain that matters to patient, and perhaps build from there in terms of how that could be approached. Psychosocial needs and outcomes. There is a massive lack of studies in young adults on PROMs and psychosocial needs altogether. There are few that mostly focus on depression, anxiety, and sleep disturbances, but very few looked into stigma, fatigue, positive affect, participation in social activities, or life satisfaction, and certainly none looked into a cumulative effect of all aspects of life through the PROMs. There is a nice study that was just recently announced and published as a pilot. It's N of 16 or 18 patients on psychosocial sequelae of stroke in working age adults that only confirm feasibility of use of NeuroQOL in assessing for cognitive and mental health outcomes. So I'm hopeful that we'll hear some results soon after that. There is another tool which is called PREMS. It's a patient-reported experience measures. We certainly don't use it in stroke readily. There is some, work in progress that I'll mention later. But there is large knowledge gap in stroke care worldwide on this matter. From few small studies, mostly from UK, although not based on a certain age population, there is a need to improve access to 6-month and annual review services. So they really want longer follow-ups. They like also to see better self-management and peer support programs, and looking for lifelong access to specialists, assessment and treatment in timely ways. So it's something that we see here in Toronto, at least at Toronto Western. The wait time can take sometimes 12 to 14 weeks for a new consult. So obviously it's the volume and access that we're talking about. So probably not feasible at the moment, but something to think about. There is a need for large studies really to deep dive into the patient-reported experience, but certainly something we should be doing. So what's the future? So the stroke community will be required to invest in the work needed to ensure that the integration of PROMS data lives up to its promise of improving the lives, not only outcomes of patients with stroke. I'm really learning the most of these measurements and application of these measurements from the papers that Dr. Matthew Reeves is as one of the leads in PROMS, certainly in stroke, and in general in outcomes. And there is a lot of wisdom in this sentence as we're moving forward to improving stroke care in general. When we see patient, we get a little bit biased because when we see someone in acute care with NIH of 20 and then improving to NIH of 3 and going home and doing really well, we're quite happy with that outcome. However, the care doesn't need to stop there. We should, as a stroke neurologist, along with our allied health support, be really involved longer in recovery of that patient, and that would mean improving their lives in addition to really doing excellent job by improving the outcomes altogether. So the future is really bright, I want to say. This is really a nice iconographics that tells us how we need to work in teams. We need to work with patient, family, and caregivers. And, this cycle never ends, from awareness to end of life, and goes from primary prevention to stroke recovery, and it comes back. Especially it comes back for young people that have a longer lifespan after stroke and are certainly at risk for another event during their lifespan. Amazing work is being done through the province and here through Toronto Stroke Networks. There is established well-enhanced pathways for patients that will go through acute care all the way to ongoing community services that helps integration and essentially provides patient education and self-management to support community re-engagement. And at the system level, through integrated team approach, there are several initiatives that will be or are already launched and used, such as cognitive orientation to daily occupational performance approach, Canadian occupational performance measures that are being used based on evidence-based outcome measure, enabling individuals to identify and prioritize their functional issues and working through problem-solving approaches really to help them integrate back. And there is, as many of you might know, Psychosocial and Hopeful Care project that's being rolled in to really help and enable patients and families and healthcare providers to optimize biomedical healthcare and to manage the psychosocial, psychological, behavioral, and social aspects of illness. So while we don't have any data yet on this, and I'm not actively involved with this, I'm hopeful that we'll hear a lot in next month and years about the outcomes of these programs. That brings me to a study that we're doing that Michelle mentioned at the beginning, and it is a Why Stroke Needs study. I'll quickly take you through, and I'll make sure we have enough time to allow for questions and discussion. So it's a study that started last year. It's CIHR supported. It's a pilot study that we're looking essentially into quality of life and patient-centered approach outcomes with assessing needs of the patients that went through experience and hopefully we'll be developing the intervention that will be next step. So, and I hope I already convinced you that this is certainly a needed study, at least at this time. And while it looks a little bit complex, it's really an intuitive model of mixed method study that is using sequential explanatory design. It's a phase 1, phase 2 study. Phase 1 is quantitative study or part of the study, and phase 2 is qualitative. Phase 1 is collecting data through NeuroQOL that I already mentioned. And essentially, we're trying to describe health-related quality of life, psychosocial and occupational functioning of young stroke through the lens of sex, gender, and age differences. And we're almost done. We have roughly 90 patients by now, and we were looking at enrolling 100, essentially needed 75 for a statistical analysis, but we're allowing for missing data to have a good data set on clearly 75, so close to an end. Phase 2 is qualitative data. It's collected through interviews. It's in-depth exploration of the phase 1. And it started in January. We're looking into 15, 20 patients. We already have 20. We're going through follow-up interviews that are now in progress, and hopefully we'll have everything completed by June. And there is already some talk about new proposal in phase 3 about intervention development that will hopefully be in the form of randomized trial. So who are the participants? Well, all young adults working population less than 65, and this is going to allow us comparison analysis of mean age, which we're looking at. It's already mean age at 50, 55, to really compare that to population groups of above and below 50 or 55. Because we can anticipate that the needs might be a little bit different given the social social context. And patients that had a stroke event, either ischemic or hemorrhagic, more than 3 months ago, and are able to participate in interviews will be offered essentially, or are offered participation. They complete NeuroQOL adult domain framework, as you can see, that really takes sort of into consideration physical, mental, and social aspects of life with integrated symptoms of emotional health, cognitive health, functional health, and a wealth of data that I hope will be able to say a little bit more than what we know by now. A lot of data variables that are collected, including modified Rankin score, as well as MoCA and many other sociodemographics, as we usually collect from our stroke patients. And here is just a sort of a preliminary quick analysis that we did a couple of weeks ago on 76 patients, roughly equivalent number of males, females. Most of the patients were enrolled at 6 months to 12 months after stroke. 95% of all patients came from home before their stroke event, and 60% went home. Again, we're talking about mild disability patients, but we don't know all the details yet. At this point, I can only say that we have roughly 66 Caucasian, about 12% Asian, and again, it's not a full data set, but interesting finding that perhaps I can share at this point is that about 80% were full-time before stroke, and only 25% are back to full-time after stroke. So again, pretty similar data that we know from earlier studies, that not many people go back to full-time after their stroke event. From NeuroQOL, while we're still reviewing T-scores, about 20% reported depression, 40% anxiety, 50% fatigue, 30% stigma and difficulty with social interactions and family relationships, 40% temporary issues and irritability, 50% had a positive affect towards well-being. So definitely a population that we can work with moving forward, and there is a tendency that people with positive affect do have definitely better outcomes. And interestingly, and it confirms that those are likely patients with not as severe stroke, only less than 5% had difficulties with mobility. About 15% reported some cognitive changes, but we yet have to review that in comparison with MoCA. We don't have more sort of objective cognitive assessment. And 20%, which is quite low, reported sleep disturbances. So again, you know, it's reassuring that it looks pretty much as we expected, but premature to say how the rest will look like. In terms of patient therapy preferences, again, interesting point where about more than 70% are looking in non-pharmacological help. And this is pretty much seen in other disease models across young population, that young people don't want to be on medications. They really want to do a root cause sort of resolution with their symptoms, rather than sort of just alleviate their symptoms with medications. They're preferring in-person mode of delivery and by professionally led, experienced in stroke outcomes people. That brings us to Y stroke phase 2, which is ongoing, but we're getting some sort of hints that most of the patients that are interviewed are looking into having a health navigator and coaches that are focused on mental health services and non-pharmacological approach, getting more physical activity than what has been provided, or if it hasn't been at all if they were discharged directly home. They're looking to licensed professionals in the form of easy access, such as through apps. They're also looking in a little bit more geared stroke awareness education on prevention towards the younger age, or even several of them ask for sex and gender focused education. So now we're in the phase 3, developing the intervention, yet not fully developed, but we're thinking about a guided program that helps people adopt a proactive and self-management approach toward lifestyle changes and healthy brain aging after stroke, which I truly believe can happen in those that had a mild stroke or minor strokes, but we need to have the tools to allow that to happen. We're also looking in the pilot of a new follow-up schedule at a Stroke in Young Adults program at Toronto Western, where I'm already following most of my young patients anyway for a prolonged time, but we'll try to do that in a more structured setting for at least 2 years and maybe even longer to really see if we could positively influence long-term outcomes and maintenance of return to work plan. So going back to this amazing work that's being done, we already developed a gap, an opportunity for practice improvement for younger patients that have minimal deficits at discharge. And they're essentially bypassing this pathway, coming back to stroke prevention clinic at 90 days and being told that they're doing great, and they're discharged back to their family physician office, where again, care is not necessarily always followed to those available ongoing community services. So some work needs to be done here, and I'm sure we'll have opportunity to enhance this for young stroke population. The same applies to those that come from other centers to us, to stroke prevention clinic directly, and we have to see how we can pair them with those services that are certainly available around. So in conclusion, I can say that we need to be more specific and should certainly focus on age and even sex subcategories when exploring long-term stroke outcomes, as they are very different across lifespan. NIH Stroke Scale, MRS, and Barthel Index are great clinical and functional outcomes tools, but certainly not good enough measures for long-term outcomes recovery, and they cannot help us for fulsome transitions of care. PROMS research can improve care and teach us something new about our patients while looking closely into their experience to be able to develop patient-centered intervention and education modules that will help them maintain health after stroke. And as already mentioned, knowledge translation within 12 enhanced pathways are needed for younger adults discharged home or first time seen in SPC or GP office. And secondary stroke prevention for all, but more so for young adults, needs detailed recommendations and education, specifics on lifestyle changes, well-being, self-identity tools. It's certainly not enough to tell them that they need to walk more, run more, and eat veggies and fruits. We have to be a little bit more specific in the meaning of it and the content of it. So, and we certainly need for there is certainly need for longer follow-up of these patients. 90 days, it's not good enough because there is a missed opportunity to help them really continue improvement and integration and transition of care into their professional and personal life. So perhaps we need to do a little bit longer follow-ups. We'll test the pilot, but still we need to assess the impact on health-related quality of life if we would continue longer follow-up. And certainly need to test the system quality improvement on integration if we're doing these prolonged follow-ups. So I'll thank pretty sort of evolved and a massive team of investigators that are helping with this project, and a couple of you on this call as well. And I think we're progressing, and hopefully in the next couple of months we'll be able to share a little bit more concrete findings and results and help move the field forward. And I'll stop here and take any questions. Thank you.
So thank you, Dr. Bakula, for your presentation. So at this time, we will transition to our question and answer period. I do think there are a few comments in the chat, so I'll get started with those. Just a reminder, if you are going to be asking a question, you need to remember to unmute yourself. So there is a comment from FQ. Not too sure your name. Thank you, Dr. Pakula, for this talk. It was very interesting. I can really see how the COPM can be used to meet the needs of a PROM and PREM, and will also help us identify what's important to the patient. As this tool gets rolled out, it would be great to see it utilized in future research.
That's great. Yeah, I totally agree. Thank you.
There is a question from Sue. Has there been any thoughts around the use of recreation therapy with young strokes to improve quality of life and help with return to activities and social connections?
Yeah, excellent question. You know, I think that's probably the frame we're thinking about. The question is how to utilize something that it's not yet necessarily already implemented in the system. The problem here is that we get to see patients at 3 or 6 months after stroke, and bringing them back into the system, it's a little bit challenging. Yes, certainly through the grant supported research can be done. We need to get funding to propose such programs, but that has to be coupled with more than just exercise. So yeah, it's excellent idea. The question is the model of it, and where and how, and the support for it. But certainly something we're thinking through the Why Stroke Needs study as a part of the next step. Thank you.
There's another question here from Jocelyn. So great presentation. Would you recommend that the PROMs and NeuroQOL be administered in all SPCs? Another question is, have you explored the availability of psychosocial services to support the young? So a two-part question.
Thanks, Jocelyn. So great point. Yes, yeah. Well, ideally, I mean, NeuroQOL in the world without COVID could be easily applied. When the patient comes here, we have tools and the means for a patient while they are waiting for their appointment to complete the NeuroQOL. Something to think about, and there is idea to perhaps do that within a stroke prevention clinic at Toronto Western as moving forward the outcome sort of model of care. So definitely in works. Talking about what the psychosocial and hopeful care program is offering, I have not explored that personally. We can certainly talk about offline about that and see how we can implement that here at Toronto Western Hospital. Obviously, I didn't talk about challenges with COVID and limitation of in-person visits and connection, which, while you're working on a personalized approach and medicine in the rather impersonalized world that COVID imposed on us, I think we have to think about how to overcome those challenges when we want to implement those tools properly. So yeah, I'm willing to talk and see how we can hopefully implement that here at Toronto Western and help our patients all together. But excellent points. Thank you.
There is another question here from Carrie Lynn. Very interesting talk and study. You discuss return to work and quality of life, but do you consider returning to driving as well? This is often a goal for clients in the outpatient setting.
Yeah, that's an excellent point, actually. Yeah, we haven't looked into return to driving. Most of these patients are actually drive and go back. I can tell you about good number of patients have no deficits whatsoever, and I'm talking about no deficits based on our NIH stroke scale. We haven't incorporated that, and we didn't have really a question or concern from a patient angle either, but something definitely to keep an eye on. It's always a question that we get in the clinic with patients that do have some limitation in driving. And I think maybe an occupational therapy person would perhaps contribute more to this question in a more sort of succinct way. But yes, that's an excellent point. Thank you.
Comment from Wendy. Excellent presentation. Thank you. There is a question from Naomi.
Thank you.
What is the problem with stroke linked to vaccination? Not sure if you feel comfortable doing that, or maybe Naomi, we can take that offline.
Yeah, I think it's a complex, it's a complex matter, and I mean there is a lot of media involved, there is a lot of opinions involved. Yeah, I think we can take that off, and I'm happy to answer in an email if Naomi is looking for my particular answer on this topic.
Perfect. Question or comment perhaps from Shelley. It would be very interesting to see how formalized social work interventions for this population, inpatient and outpatient, would impact. Patients are expressing a desire to have non-pharmacological interventions in identifying psychosocial and mental health issues. Investment in social work could really make an impact on long-term recovery for this population. This would be interesting to study.
Excellent point. That brings us to many different modalities that patients are asking for in terms of how they want to approach the non-pharmacological means of care. And let me just try to go back to that list, which is quite eloquent list, and we just put solution-based therapy, problem-solving therapy, music, yoga, and mindfulness. And each patient, before they would answer this question, would get education what those therapies mean and the definition of each. And I can tell you, talking to Dr. Katie Sheehan, who is a co-PI on this study, and she is a psychiatrist who does a lot of these interpersonal therapy approaches for our young stroke patients. What she had reflected and back to us after seeing those results is that we certainly don't have educated people to provide this type of care. So if there is a mode in terms of educating, a social worker to be able to provide this type of therapy and invest in that sense, certainly it's one of the options that one could think of, at least through the study, if not really through a quality improvement model. Because what we're seeing here, and we'll be seeing this more and more often, is that people are asking for what it's not yet available in the system, and we should certainly invest funds and educational support to be able to provide those for those asks. So excellent point, and I think that that would be the way to perhaps pursue this. Thanks.
Question from Ravinder. So great talk. Thank you. Do you think underlying depression would affect all PROM domains and inflate the scores in all domains? And a follow-up question to that is, are PROMs geared towards milder stroke populations?
Yeah, so, going back, I mean, there is this thought that most of, Integration issues are leaned on a cognitive impairment, which I think we have to tease a little bit out, and the same applies to depression. So yeah, there is a possibility that a lot of it is masked by depression. And we do have data on pre and post stroke psychiatric conditions, and so we'll look into that really to perhaps try to at least and contain the answer to that question if it's difficult. What affects prompts most of the time, it's really, people can have a good or bad days when they're doing the questionnaire. It's very subjective. It's not an objective tool, and I agree with that. It could be affected with environment, with many other things. So I don't think we'll be ever able to answer that question. How mental health affects the overall prompts. But one possibility is to look into comparing the population that has a strong positive affect towards well-being versus those that don't, and see what comes out of that. So that's one option that we were entertaining when seeing this data. Remind me, please, what was the second question? I'm sorry.
I'm actually going to say perhaps we will address the other questions. There are about 3 other questions in there, but I'm just looking at the time. I think what we'll do is we'll get those questions to Dr. Pikula. We'll get her responses, and we'll email those out to you along with the link and the slides for today's session. So just a quick reminder to everyone to please fill out the evaluation. There should be a link in the chat box that would allow you to get to that. The next provincial stroke rounds will be held on June 2nd and will be hosted by the Champlain Regional Stroke Network. The presenter will be Dr. Jeffrey Perry, and the topic is on the results of the most recent ED TIA study and the Canadian TIA score. So once again, I'd like to extend a very special thank you to Dr. Pikula for joining us today and for her presentation. And I would also like to thank you all for joining us. Wishing you all a fabulous day, and we'll see you next month.
Thanks a lot. Take care.
Thanks, everyone.